My name is Lisa Morad McCoy, and I think all of you who are here have been here before, so welcome. This is our 7th or 8th clinical supervision echo, and I've just been excited about the support that we've had. As you all know, this is an echo, so the first part of it is going to be didactic, and our presentation is going to be given by Sonia Briones Parks, who is here and also part of the Echo Hub team. And then the second part is going to be a case review based on a case from an anonymous case submitter. So we will get started with all of that in a bit, but first let's do some quick Hub team introductions. So I'm going to pass it to Sonia. Actually, no, we're going to do Sonia later. To Jen.
Jen Panhorst, LCSW. I am the interim director of UNM's Masters of Social Work program that's in development. I will send it to Denise.
Denise Moore, I'm an LPCC. I am the clinical director of Terranueva Counseling Center of Southwestern College, which is a graduate school for counselors and art therapists. I'm going to pass it to Brenda.
Thank you. Good afternoon. Buenas tardes. I'm Brenda Quiñones Cortez, and I'm director over at El Puente de Encuentros, a nonprofit that supports students of color pursuing careers in mental and behavioral health. And I will pass it on to, well, I won't pick on Sonia because she's gonna have her own special intro. Where did Betty go? There you are. Oh, you're on mute.
Sorry about that. I said I'm Betty Downs. I work with the Behavioral Health Services Division and the project manager for this wonderful ECHO series. I always like to make a plug. Those of you who are in it before, this is no surprise, but I just wanted to say to others, if you can share, does that show, Lisa, share screen? Okay. Over in NM Recovery is a dedicated place under resources for clinical supervision, and the implementation guide is there to be easily downloaded for all of you. And just to plug that we're going to be building a space for the didactic materials that have been presented over this period of time, so that you'll have another place you can quickly go to get materials. So just wanted to say that. If I can get out of this, I will stop sharing.
Thanks, Betty. And I think we also have Lacey Keith.
Yes, I'm Lacey Keith, LPCC CEO for Mental Health Resources.
Perfect. And I think that is all of our Hub team today. And we encourage you to introduce yourselves in the chat so that everybody knows who you are and what your role is in the community. So now we will go ahead. I'm going to go ahead and introduce Sonia. I was super excited to have her present today. And yes, we're very much looking forward to it. Let me find. Okay, sorry about that. Sonia Briones Parks graduated with a master's in art therapy and counseling in 2009. She is a licensed clinical mental health counselor, LPCC, and the placement services clinical supervisor at All Faith Children's Advocacy Center, a trauma-focused agency. She has worked with children, families, and young adults in outpatient, inpatient, and community settings. Sonia has served over a decade in her community, mitigating the intersection between mental health and social justice. Her focus is using culturally aware, trauma-informed approaches to support both clients and supervisees. She currently supports the placement services team with their critical work with birth parents, adoptive families, and foster children. Sonia believes in building community resiliency one family at a time. Wonderful. Okay, Sonia.
Great. Thank you so much, Lisa. Okay. I'm going to share my screen and it's going to go great. I can tell it's going to be fantastic. Let's see here. Minimize a couple things. Okay, how am I looking? Is this pretty good? Okay, thank you, Lisa. Okay, so for today's focus, we're going to be talking about countertransference in the supervisory relationship, and then sort of the ethical challenges that can come across from that. Once again, my name is Sonia. This is some information about CEs, and I think we're going to cover this again later.
Yeah, I'll just quickly say that you need to stay for the whole time to do CEs and then fill out the evaluation form as soon as you can, because after 48 hours, it's gone. But we'll talk about it again.
Sure. Great. Thank you, Lisa.
Mhm.
And so I just want to make sure I'm bringing this out that I do not have a financial arrangement related to the content of this activity. And then this is my disclaimer that, again, the views that are expressed in this presentation are mine and do not necessarily represent the views, policies, and positions of UNM. Okay, so here are our learning objectives for this brief time that we have together. We're going to look at some terminology as far as like a refresher on transference, countertransference, and then how these dynamics play out in supervision, and the ethical challenges that come across through that. We're also going to be talking about some different strategies that clinical supervisors can use for managing countertransference ethically in the supervisory relationship. We're hoping that maybe some of these concepts that we talk about are going to also apply to the case example after this. It may not, but hopefully you'll be able to at least reflect on the information we talk about for your day-to-day practice. Okay. So to me, this quote is just a reminder that transference and countertransference can be useful to our work if they're kind of used in a constructive way, if we're aware of them. It does not have to be this super negative experience or situation for folks. It can actually be something that's helpful. It helps us get insight into the inner world of the patient or client, therapist, and supervisor. Okay, I'm going to slow down a little bit. I get a little chatty. Let me know if you have any questions. We're going to look at some terminology. So again, this is probably a refresher for folks, but just to make sure we're on the same page, we're going to use this sort of working definition of clinical supervision as that professional relationship between the supervisee and the supervisor. You know, it's supporting self-reflection, it's helping supervisees build their clinical skills. Maybe there's assessment, evaluation, and hopefully there's some joint problem solving that's happening in that relationship. When we look at transference and countertransference, you know, these concepts are rooted in psychoanalysis. But you know, the research really is showing that these concepts are relevant to all therapy approaches and to providers because we are human and we have emotions and responses, and it's totally natural to have those. So let me go back to transference actually. So transference is a common occurrence and it shows up in a lot of different ways with clients. So this is when a client is unconsciously transferring or projecting their feelings from a person in their life or their history onto their therapist or provider. Countertransference is similar. It's kind of a mirror where instead this provider is projecting their unconscious wants, needs, and feelings onto the client. And this is evoked by the transference of the client. I want to say that countertransference, it serves as a source of insight into the client's effect on other people. So if we're experiencing the client in a certain way, it helps us bring insight into how other people in that client's life might also experience them. Like I said, this countertransference can be really a productive piece of a therapeutic process if we have awareness of it, and if we were actually responding to it in a way that is helpful. Sometimes we are not aware, and so we have to do some checking in with ourselves to see where we're at with it. For our purposes, I hope this isn't too confusing and I'll try to be clear, but transference could apply to the client, countertransference to the therapist, but we could also be talking about transference for our supervisee and countertransference for our supervisor. So I'll try to make those distinctions as we move forward, but I want to talk about both of those today in this short time. So hopefully that makes sense to everybody. Okay, go ahead. Okay. So when I was, kind of thinking about countertransference, I came across some research about this concept of using countertransference as more of a spectrum kind of model, where we have extreme responses on one end and on the other. So very extreme negative and positive and everything in between. And I really like the idea of this concept for working with supervisees. Using this language, maybe even drawing this out on a dry erase board of what that spectrum looks like. So talking to your supervisee about, where are you on the spectrum of your responses with this client right now? Helping them kind of understand how they're feeling and if, they're having extreme responses. I want to talk a little bit about some signs that folks are having CT, especially if you're working with your supervisee and they're not really bringing it up very much, or you're picking up on some strong kind of emotional reactions to their client and they're not maybe discussing it. So one thing I like to ask my team are questions like, what client comes to mind the first thing in the morning for you? Like who pops into your mind the first thing in the morning? Which client, as you're trying to go to sleep at night, who is coming to mind? When you're having these quiet moments in your day, who is present with you? Because that could be signaling some countertransference. We also want to be clear, I'm working at Allface, which is mostly focused on trauma. And so I'm very aware that some of that could be like a secondary trauma response. And so that's also something to think about as we're talking about this. It's not necessarily one or the other. It could be all of these things that are showing up for us. But those are just some ideas for kind of like helping folks bring awareness to their countertransference. Some common responses that providers might have are strong feelings of like and dislike, on that spectrum, right? Maybe just thinking about that client is bringing about a lot of anxiety and distress to them. If you are, if the person is in session and another person in their personal life, comes up in their mind, that could be a pretty clear signal of countertransference. Feeling overly protective or defensive of a client, This is one that in my work I've had to really try to address because I mostly work with kids and teens. And I feel like I have a natural inclination to be protective. And so I've had to really address that in myself and in supervision to make sure I'm not doing too much, like taking on too much for my clients. We want to think about if we are overly self-disclosing more than our usual sort of way of doing disclosure with clients, then that could be a sign of maybe you're too close or there's some kind of countertransference happening there. The same thing for being overly attached, overly supportive, um, having frustration or anger towards a client if they're not making progress. I think some of that is natural. There's some nuance to these responses, but I feel like if it's something that feels, again, more extreme than usual, then that's telling you that something's popping up. And then offering advice versus listening to the client's experience, that kind of, depending on what's going on, that could be sort of like a savior type of mentality that's popping up for you. So just making sure that we're thinking about that. And then that last one, which I think is one of the more challenging ones, is romantic attraction to the client. Um, that one is really tough for folks because it's maybe one of the more difficult ones to bring up in supervision, but it's also one of the more ethically difficult pieces to think about. Um, for our clients, I want to mention um, that transference in your clients could also be something to think about as far as like, what does that look like? So sometimes our clients are pretty transparent and they might say something, have a head kid say like, you're my best friend. I wish that I could see you every day. That's kind of telling me a lot about where they're at with me. But other times it's not as obvious. And so I want to look at in session posture. I want to look at, do they have clenched fists? Is their foot tapping a lot? What's going on for them, not just because of a, clinical curiosity, but also maybe that's a sign of something more. So those are just some ideas for observing, clients. This would also, of course, apply to our supervisees. If we're noticing our supervisees are kind of having some nonverbal cues that are showing us something, then we need to kind of make sure we're thinking about those things. What else can I say here? Yeah, I think you can see how just this short list, which is definitely not every kind of response we could have, you could see how these responses could raise some ethical concerns. If we are being overly protective of our client, you can see how that could impact your ability to challenge them in session and to make treatment decisions. You could think about how feelings of dislike could impact rapport, and all of that impacts the progress of the client. I think there's some comments. I want to make sure, am I missing anything in the chat?
That was just me saying you
Okay.
have about 10
Okay.
to 12 minutes. Yeah.
Perfect. Thank you. All right. So this resource, I really like this resource. It had a chart and I've adapted it from this chart that had several different types of CT responses. And so I just wanted to highlight a couple because I know we don't have a ton of time. But I thought this was helpful. We have the type of CT response. We have some typical thoughts, reactions, behaviors. And then that last column is a therapeutic reaction. It could also be a plan, like a way to move forward. So if we look at that last one, I want to talk a bit about that response because I feel like talking about having erotic or romantic attraction to a client is one that people might have a hard time bringing up in supervision. And so I want to make sure we talk about that. Um, some typical thoughts might be that, that client is fine that you're attracted to them and they want to be with you. Maybe that provider is also romanticizing the client and feeling like they're in a trance when they're with that client. Some typical behaviors would be being overprotective, flirting, trying to kind of bring up sexual activity. Of course, the behavior that we really don't want to see is engaging in that activity with a client. And then, how do we respond to these things? So, hopefully, that provider is going to be seeking out supervision or consultation, maybe even personal therapy, doing some self-reflection to understand their own motives. And if these things don't work, then we need to think about changing that therapist, transferring. And then, of course, not engaging in a relationship even after the client discharges. So, anyway, this resource is in my references because I thought, there's a bunch of different ones like this that we could think about. Kind of a nice shorthand if we want to think about how these all connect to the response. Okay. Okay. So like I was saying, a supervisor's response can really parallel those of the supervisee. And so I want to talk about CT in the supervisory relationship. Um, you know, if we have unconscious CT, how, that can definitely affect the supervision process and our supervisees' learning. We could be undermining their self-confidence if we're doing, or leave them discouraged if we're doing some of that protective sort of response, if we are really not allowing them to make their own choices and have their own decision making, that could be undermining their self-confidence. It's important that we're aware of our own influence, our values, our beliefs, how all of that impacts the relationship, the supervisor relationship. Um, it's important we think about dual relationships. I know that these are challenging, especially if you're living in a small community where everybody knows everybody. That is something that could be really challenging, but I have seen people do it effectively, like managing those roles. Um, I wanted to put in here a quote about power because I think it's very relevant. So as a therapist may have significant power over the client, the supervisor may also have uncontrolled power over the supervisee. This one I think is very relevant, particularly to folks who are like me, who I'm not only doing clinical supervision, but I'm also doing administrative supervision. And so I need to remember that my power, I am the one who signs off on time cards. I'm also the person who does performance evaluations at the end of the year that could impact whether or not they get an increase in pay. And so I want to make sure that we're kind of thinking about how all of this plays out as far as a power dynamic and folks' ability to feel open and talking with us. Let's see. It's important we address, cultural identity and power differentials, like I just said, because all of that, could be inherent in the supervisor relationship, that making sure that we are following our best ethical practices, and that we're seeing supervisees' reluctance to change as a normal response to being challenged. It doesn't mean that they are stubborn or, whatever the language would be, making sure that we're seeing it in a more open-minded way. And then I just reminding us that we need to be engaging in self-reflection. And I'm just going to show a slide on that. I found some great questions on self-reflection. We're going to talk about just a couple of those. I wanted to highlight a couple. So I like this one, am I able to give the provider negative feedback and alert them to mistakes directly, or do I apologize in advance? Kind of like that feeling, am I walking on eggshells with my supervisee? What is that saying about this supervisory relationship or about CT? You know, am I supporting a client against a supervisee? Just some different pieces, a lot of good questions for ourselves to be thinking about. Okay. So, you know, as we've discussed, countertransference on its own is normal and can provide us with a lot of insight into our clients, our supervisees, and ourselves. It can become a concern when it's unmonitored and, you know, if providers are allowing their emotions to compromise their ethical standards. And so, as a supervisor, you know, our primary role is really to safeguard the client. And we also need to create a safe environment that fosters trust and openness with our supervisees, and making sure that we're addressing parallel process issues in a appropriate way, where they're at developmentally, that we're being supportive of all of this. Um, if we're not doing those things, then we could definitely come up across some ethical concerns. Let me fast forward this. Yeah, so just a couple of things to highlight here. I know that there's lots of ethical guidelines that every field is kind of having to navigate. And then I was kind of thinking about some commonalities between those, between social work and counseling. I work with CSW, so I know they have their own sort of regulations. And so just again, making sure that supervisors are aware and responsible for managing their countertransference, that we know that that lack of awareness could impact the supervisee's learning and growth, that we are conscious of our emotional reactions to certain clients, supervisees, and situations, and how that could steer a supervisee in one direction versus another. Making sure we're, you know, aiming for objectivity and thinking about our judgments, our feelings, and how those could impact the development of the supervisee. And that last piece is just being conscious of, you know, are we being overly critical? Are we omitting constructive feedback? You know, where are we at with how we're supporting our clients and our supervisee? These are some strategies, and I know we're coming up on time. These are some strategies for managing CT, and I am guessing that if we did a poll that you guys would have a lot more ideas than this, but I wanted to put out a few. Again, being mindful of power dynamics, being aware of how culture and bias could impact our responses, tracking our somatic response. I think it's a really helpful process to do a body scan during supervision when your supervisee is talking about their client to see, you know, where are the tension areas, what's going on with them internally, to help sort that out. I think supervision, consultation, even personal therapy could be very helpful for exploring these kinds of issues. And then, you know, ongoing training and education. What else could I say here? Yeah, there's a lot of different ways to find to manage CT in and out of the workplace. And then I think this is lastly, just again, I want to have that message out that, you know, managing countertransference can be challenging, but it also can be very valuable as a tool to use for understanding the dynamics that are happening with the client and your supervisee. Also with us and our supervisee, right? It's kind of both of those. It helps us gain better insight into the responses that are happening in session. It helps us identify strengths and growth areas for the supervisee and build empathy for the client and ourselves. And so I just wanted to give a little pep talk to countertransference because it is valuable, because it could be very helpful for us as providers and as supervisors. Here are my references. And then any questions, I can stop sharing.
Thank you, Sonia.
You're
Yeah,
welcome.
any questions, resource sharing, sharing of similar experiences in terms of your own practice, you can either write in the chat or even better, raise your hand and unmute yourselves. Okay, Jen.
Yeah, I just wanted to thank you for this presentation, Sonia, and especially bringing up the idea of positive countertransference, because I think it's very, in some ways, negative countertransference is a lot easier for everyone to name. And it's a lot harder to recognize having a positive bias. And I think that gets a little bit to some of what you were saying about erratic countertransference. But I think there's other ways, where people, right, a positive association with a friend, a relative, et cetera, can create that bias, where somebody does get favoritism, where, right, feedback is withheld, things like that.
Yeah, definitely. Thank you. Cool.
Thanks, Jen. Anybody else? Questions, comments? Sonia, I love that you pointed out that countertransference and transference among clients and therapists and clients and supervisors and supervisees is all normal. And because I think there can be some amount of shame around it. And I don't know if you've ever experienced people having difficulty bringing it up, or it comes up after, a person's been seeing a client for a while and you're in the supervisory relationship for a longer period of time and then it comes up. Just curious.
Oh yeah, definitely. I've seen that a lot, especially when I've had people who are like newer to the field. They feel like, oh, I'm weird for having these thoughts or these feelings. And so I'm really trying to bring it up right away in in supervision, like pretty early on in supervision of like, um, wow, your client's mom, I don't even know her, but I'm getting stressed out by her. Like it's really trying to normalize that in that way to kind of get that conversation going so that they're not feeling that is a shameful thing or it is like a strange concept. I think it happens all the time. Even in our daily lives, you meet somebody and you immediately have a connection or you immediately don't have a connection. I think that's reality. So.
I was wondering if anyone has experience supervising folks who have like different credentialing than you, or who maybe don't have an official credential, like a bachelor's level person who maybe doesn't have sort of a license, right? Because a lot of these conversations can be housed in like, this is our ethical practice. So just wondering if folks have found other ways to talk about ethics more broadly for, when you can't point to a certain board.
Claire, I can chime in on that. So I've overseen peers and CSWs for the majority of my career. And I tend to just lean towards the counseling ethics code for our CSWs. So peer support has their own code of ethics, but for CSWs, for when we were doing BMS work, to really just kind of lean into the ACA code of ethics, because it sets out some good guidelines as far as the appropriateness of dual relationships and client interactions and client abandonment and the do no harm kind of pieces. to lean into, while you're not saying we are beholden to the ACA with this individual, just saying that these are the ethical guidelines that really guide good client care. And so leaning into those has been helpful.
Great question.
Sorry. I would also say that just understanding their scope of service and helping them to understand where their scope ends and, you know, maybe the therapy scope begins is also a huge component of that as well.
Great question, Claire. It can be a challenge to supervise people who are at a different phase in their career or, you know, a different licensure than you. And I think, I mean, my style is to be pretty transparent about it and name it fairly often and just say, you know, it could be that the person is teaching me along with, you know, also learning from me. So I think that, and, you know, I know that that's a common way of doing supervision, but it does tend to work pretty well. Denise.
Yeah, I was just going to add as well. Sometimes you can locate that not necessarily boards, but other professional organizations that kind of hold certain ethics or ethical guidelines for specific roles. For example, like for victim advocacy, there's specific kind of rules and ethics that are, I think, couched in a lot of counseling ethics and social work ethics, but also kind of important in the role of like a victim advocate. So I guess it also depends on, you know, the role of the worker, but even doing some little sleuthing on are there ethical and standards for a specific role sometimes is what I do as well.
Great point, Denise. And I don't mean to cut this short, but we have a great case, and so we're running short on time. However, we always do offer staying after for 10 minutes if you have more questions. So